the aisle, it will be collected and brought up here to me as well. And finally, we did ask for questions when we sent out the invitation to the event, and we'll try questions. So please keep your time in front of the microphone focused to avoid any personal health questions, because we want to support patient privacy in a public forum such as this. Instead, on the card you put up by hospital staff. Okay, with that introduction, let's get it. So Denise, I'll start off with the first question. There are folks in the audience tonight who are just meeting you for the first time. Tell us a little bit about yourself.
Sure thing. Well, I grew up in East Boston, and my parents met when my dad was in the Navy, stationed in Charlestown. He was from Illinois, and Mom was from East Boston. So my roots go all the way from East Boston to a little town in the Midwest called Joliet, Illinois. So, and now they're here on Martha's Vineyard. My dad was in the Navy, and they got married very young. And being 19 and being away from your wife and then children for many months at a time doesn't make for a good marriage. So sadly, they got divorced very young. So I really grew up in a very large, extended family in East Boston. And my grandparents, who I wouldn't be able to talk about why I'm here today without talking about my grandparents. So please indulge me a little bit, because through them you'll get to know my values and who I am. So my parents came here in about, their parents came here at the turn of the century. They were second generation Italian here in this country. My grandfather had a third grade education, and he was probably the smartest man I ever met, or I should say the wisest. He may not have had a master's degree or a business degree, but he always paid cash for his homes, his cars. He never owned a credit card, and there was always food on the table. And why I say he was the wisest man is he had just the simplest values and the simple. And I think of the things he taught me. And I think they probably can all resonate with you. He would say things like, treat people the way you want to be treated. Give and you will get back so much more in return. Always be kind to others. If there's a will, there's a way. That was his famous one. And his other famous one was, it's a good life if you don't weaken. So tell me he wasn't a wise man. He shined shoes to make money. It was 2 cents for a pair of shoes, a nickel for a pair of boots. He was very proud of his heritage, and he understood compassion and humility. A neighbor asked him, and told me this story, and I always remember it, where a neighbor who had boots with more holes in them than Swiss cheese said, you know, Charlie, my boots would look so much better if they were shined, but I can't afford a nickel. And he said, you're a paisan. And with those holes, I'll give you half price. Charge you 2 cents. So that was my grandfather. And the moral of that story is they were all about giving back and being compassionate and be thankful for all the things that they were blessed with, family, food on the table, and good values. So I carry them around with me. And, you know, we grew up right on the harbor in East Boston, right near the airport. My grandmother used to go and pick, everybody know what jagottias are? Dandelion greens. They now charge you $14 a salad for one of those here on the island, maybe 20 here on the island. And she would sell the dandelion greens, and that's how they made their money. So they were very precious to me. But we grew up on the water near the airport, and we walked. My cousins and I played at the airport terminal. One day we walked on an airplane. So much for security. We literally just walked onto the airplane. And so being close to the ocean and the water was just something I just loved. It was in our blood. I learned to swim in the Boston Harbor. Yeah. So the first time I ever stepped foot on this island, imagine, the difference. And I just fell in love with the island and knew someday I would live here. And it was a long path, but boy, it seems like yesterday. And my waitressing days paid for college education. If anybody knows the Hilltop Steakhouse, Frank Jafrida, God love him, I made more tips on a weekend than I did my first job at Salem Hospital, but it paid my college tuition, or it helped. And went to Boston University and thought I was going to be a doctor. But then I had to do a clinical affiliation. I started working at Salem part-time, and I never left. They kept promoting me. So I ended up staying there 24 years. Some of my people are going, yeah, I know how that happens. But I liked the business of healthcare. But I worked in the cath lab for 10 years, so I did clinical cardiology. So I did patient care for a while. And there are stories that I remember and I will never forget, and they just teach you to keep your humility. Because never forget, no matter what happens, there but for the grace of God goes any one of us. And boy, if it takes compassion and humility to be in healthcare, and I'm blessed with a great staff that have nothing but that. So then off I went to grad school. I had a hard time taking off my lab coat, so I didn't do the MBA route. I got a master's in public health, still wanting to do, do good. Good will come back, do good. And then ended up going to Tufts Medical Center for about 13 years. Then I was at Metro West, and I thought I was going to retire. My husband, who's here in the audience somewhere, is my lifelong friend and mentor also. And he's a retired school teacher, and he's a little older than me.
You can get away with that.
Yeah, he's a little older, but he retired, and we were living here. We built our house in Vineyard Haven in 2000, so we've had a house here for about 18 years, and we had our honeymoon here in 81. So I loved the island, and I knew the island, and I still took the job. So that's my story.
That's great. Thank you very much. So once again, if anyone has any questions, feel free to come up to the microphone. And as we're waiting for you to come forward, another question for you. What's your early vision for the hospital and the vital partnership that it must have with the island residents and visitors?
Well, my early vision is just that. When I first got here, all I kept hearing was that the hospital's not transparent and they don't collaborate with the community, and there's not enough primary care doctors, and you all that the hospital seemed closed. And so I made a point in my first few weeks and months to let everybody know I had an open door policy, and to meet with all of the various agencies and the key folks in the community. And you still call me and write me, and I love every minute of it. It's how I've learned about the challenges here on the island. And many of you, as I see here in the audience, have been in my office, and we've talked very candidly and poignantly about some of those issues. So through those meetings, it really helped me to formulate what I think the short-term vision should be and needs to be. And then I'll tell you a little bit about the longer term. So short-term, the big theme was access to services. And it's really access to primary care, access to specialty services, and certainly access to substance abuse services. So let me tell you a little bit about this. So that's sort of vision number one, is to really look at the access issue, try to see where we can put our energy. And I do have some great news to share with all of you about that, and we can maybe address that through the future questions. Longer term, what I hope to do is, we built a beautiful brand new hospital 10 years ago now. And, healthcare is radically changing. Most of the care is now shifting to outpatient, and the demand for outpatient services are greater. The reimbursement's not as good as inpatient, but it is better for patients, better for patient care. We can do a lot on the outpatient side. We're a little bit rusty in terms of our buildings and services. Not at the main hospital. Our technology is great, our equipment is great, but our space on the ambulatory side is tired and not conducive to expansion and growth. So if any of you have been in my hospital, you've seen those wings. I call them bowling alleys. And you probably know what I'm talking about. So we really need to have a strategic plan that looks at the demand for services that we need, then a master facilities plan to design a facility around the community needs after we complete an assessment, and then look to see what we can do to meet that strategic plan, perhaps either in a capital campaign or some new buildings. But that's about an 18-month process, I would say. We'll begin that in the fall. And that is my vision, is to really create that ambulatory center of the future that many places off island have today, and to look at the services that we can probably bring and keep here on the island so that you don't have to go off island for some of the basic things like a breast biopsy, for example. And then also the longer term issue, and it's right up there, and I'll put it right out there, is what do we do for community, for elder services, and how do we deal with, not only the Windermere issue, but elder aging on our island. It's a community issue. It's not just my problem at the hospital. It's all of our problem. So I've been spending a lot of time with community members and some outside folks to explore options, and that's what we're going to do. We're going to, together as a community, look at what we can do, what's the right thing to do for this community, um, try to have a more contemporary model, a more dignified model for elder care here on our island. And we'll do that together, folks.
Great. So we'll do here, 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 right? So if you could just introduce yourself and tell us
Thank
where you're
you.
from.
Ebba Hirta, West Tisbury. Thanks for holding this forum. I'm going to violate your term and first start with a comment and then a question. And my comment is I'd like to give a shout out to your employees who couldn't be here. And they couldn't be here because they don't live on the island. They commute. Okay. And they are just as important and just as dedicated to the health and welfare of this community, the patients at your hospital, as the people who are lucky enough to be able to afford to live here. Did you know during our ferry debacle, those people who stood in line in the rain and the sleet and the snow waiting for a ferry that never came, they had their pay docked. That's not acceptable. Those people dedicate themselves to this hospital, to us, these patients. That sacrifice should be recognized. I don't think you can staff the hospital without them. So you should recognize the hardships they go through and help them instead of hurting them when the ferries don't run. So that's my comment. And my question, I had a few, but let me pick one. Women's reproductive health. There's a serious dearth on the island. There's no abortion services, no matter how early, how desperate. Women have to go out, even for the pill. And that's a multi-day process. It's very expensive. And I hope that you're looking at that, and that's something that you can address going forward. Thank you.
Thank you. So let me address first the comment, okay, because I can't answer the question without addressing the comment. Every employee that works for our organization is important, every single employee. Today I did an orientation with about 30 people sitting around the community room, newcomers to the island and to the job, most of them just for the summer. And the opening line I said to them was, I don't care if you're here for a day, a year, or 40. You're our employees. You're here. We want you to be part of our culture. I talked to them about our core values, what they give, what they can expect, what they will get in return. So every employee is valued at our hospital. I don't care what you work, what job you have. It is our number one core value is our people. On the abortion issue, on any new service, any service that I think about providing in general, I think about really two things: scale and resources. Scale and resources. Do we have enough volume, that's scale, to do it well? Okay. And do we have the resources to do it consistently and well? And on the abortion issue, no, we don't do abortions at our hospital, and we will revisit it, but right now we're not planning to start an abortion service at our hospital, and I'll tell you why, and Dr. Pesh could chime in a second. But the reason is most women ask us for options. option planning. They don't want to have their abortion here. They want to go off island. So we're doing alternative counseling. We're doing options counseling. We do get them to medical termination services if the mother is at risk or a baby is at risk. So again, it's scale and resources, and we don't always have the resources to consistently do that. I don't know, Dan, if you want to add anything.
So we do have actually a robust women's health service on the island. I think we do very good work. So can everybody hear me now? So I think we do have excellent women's services. There's not a dearth of services here. And in fact, we have, in combination with Mass General, a very robust fetal diagnostics program. Pretty much everybody on the island, and we'd love for them to come to the island, but that's something, again, we talk about resources. In order to provide the same care that you'd get if you went to Boston, we really need you to go to Boston. There's a huge component of counseling that comes from genetic counselors. There's ultrasound, there's diagnostics, there's blood work, as well as ultrasound, and then the availability of maternal fetal medicine. And we don't have that here on the island. And so when I tell somebody that I'm going to send you for the same care, and we spend a lot of time and energy on this, when you talk about that program, the program has to be fully staffed and fully supported. And right now, I agree, we don't have the ability to 24/7 support that kind of service. Now, when people come in with problems through the emergency department, nobody's turned away. And we do provide options counseling. We work with Friends of Family Planning and Health Imperatives, who staffs the reproductive health clinic on the island. I'm, in fact, on the board. We worked with them, with the rural scholars, to actually study and look at the volumes that we have. And right now, even when I talk to some of the other agencies that could potentially provide the service, they're reticent to try to bring in staff to the island, even on the Cape, because of the volume. Because they have, it's a challenging time to pay for some of these services, and they're all looking at how are we going to pay for that. I mean, it's a big issue off the island as well, but I agree, we're all willing to work with any of the community agencies. We do want to meet everybody's needs, but I think that, in a challenging time, I think we provide excellent services, and we won't turn anybody away, and we will find help for people. I think we do a really good job. And there is funding available through Friends of Family Planning for people to go off who can't pay for those services. So there are a lot of good, there's a lot of good work on the island, and the hospital will continue to work with those folks. So, thank you.
Thank you, Dan.
Terrific. Thank you for taking a seat. I will keep my eye on you. Yes, you should not have to stand. Please, and the second person, feel free to take a seat if you'd like. I'll keep my eye and make sure you won't lose your place, I promise. Thank you.
Hi, I'm Roberta Kern from Vineyard Haven, and I have a near and dear one who's off island in a nursing facility, and I wondered in the short term about if there's any vision for, I know there was a wing closed at Windermere. We've been on the waiting list for 1.5 years. It's not working out. Are there any thoughts for now? And then the second part of that is, will there be opportunities for people like me who have real, immediate concerns to chime in the conversation about what will develop in the future? Thank you.
Absolutely. Right now we have 60 beds that are operational and open right now, and pretty much they're full. We have a hard time keeping staff there. We're sort of limited at the 60. 80% of our staff are travelers, and so between the cost of hiring them and housing them, it really is difficult to, again, provide that consistent care and continuum of care that's so vital to our elders, right? I mean, to change caregivers all the time, especially if you have dementia, is very confusing. What we're trying to do is give, it's not all, because we're full, what we try to do is give preference to, if somebody's already in our hospital in what we call our SNF bed, so we have the ability to take the 25 beds that we have in our hospital and level them to skilled nursing care. So if your loved one was in the hospital, needed more nursing care, rather than send them off island, we tend to give them first preference for the bed that opens up. It's sad, and I wish we had more capacity, but we don't intend to build more capacity at Windermere right now, and I'll just be honest with you about that. We are working on looking at the greenhouse model. We're going to be talking to some assisted living folks that have approached us about building a new model together. We've worked with Alice Bonner, Secretary of Elder Affairs in Boston, and there's a lot of ideas out there. But it's time to put a stake in the ground and really carve out what we're going to do. What are the ideas? What can we do on day 1, day 2, day 3? Windermere's the past. It's not the future of elder care. It really isn't. We will not close Windermere until we have a solution and a plan going forward. So I want to be very clear with people. And yes, you will have an opportunity. We will hold forums like this. We're inviting community members to be part of strategic task forces that we'll be putting together. And we'll be starting some of that work in the fall. We're going to be hiring a consultant to look at all the various business plans and options being presented. And I hope to be a real leader in this front with a lot of my key colleagues here in the front, Patty Moore being one of them, and Peter Temple, and so many people that have an interest in this issue for us on the island.
Take your time.
A little stiff there.
It's all right.
Many of you I know, I'm Dr. Lorna Andrade, and I live in Edgartown, and I've been very involved over 30 years here with professional nursing education. I taught at Mass Bay Community College as well as the University of Massachusetts, Boston, and Dartmouth. I delivered distant learning classes here on island by way of Nathan Mayhew Seminars, which is presently our 8th home MV over there. Our president from
Sam.
Sam is
There's
here.
Sam, yeah.
Yeah, so we've done a lot of different things in education here on the island, but we need a lot more done. And my question to you today is, what diversity education, also cross-cultural education, are you going to employ with those being hired at the hospital at the present? My rationale for this is I do a lot of patient advocacy here as I'm retired now. And those who have many concerns are concerned that people don't understand the cultures. Now, for example, I did my own genetic screening, and I find out I'm 17% Italian.
Yay.
Northern Italian at
There you
that,
go. Uh-oh.
okay? All right, so that's just to give you one example. So as doctors know and professional nurses know that when you do genetic screening, you can better take care of individuals. You can better prescribe medications and all. So I say to you, we have to know from where we came to know where we're going. I had a lot more questions, but I think I covered it all here, and I'll get to you all later.
Thank you, Dr. Andrade. Really well put. I couldn't agree with you more. You know, diversity in any workplace, and especially in healthcare, enriches what we do every day. So cultural awareness, different perspectives, different thoughts, different cultures, only enriches the healing environment. And I think we can always do better. There's always room for improvement, but we don't discriminate. And we look to have a diverse organization. And, you know, if you've been to my hospital, you'll see the diversity that we have within there. So I do agree. I'm also thrilled to hear about your teaching background. We might take you up on that. We have 17 nursing students that come from all over with us this summer for the experience. And that they tell us they get here in the community. So from UConn, Northeastern, where else, Carol? UNH. Today there were half that community room was filled with nursing students who want to, some of them are, family members of people that live on the island. And so we encourage this so they'll want to come back to the island and live and practice. And we have a nurse in our dialysis center who was one of our nurse trainees and who now is one of our stellar nurses in the dialysis center. So learning and teaching and diversity just enriches the organization. I couldn't agree with you more.
So once again, please feel free to come forward with questions. I'm going to ask you a big question that we had a number of folks email into us, and guess what that topic is? I'm going to use one word and see if you can fill in the rest. Primary. There we go. All right, Denise.
I'm so glad you asked that question, Peter.
With audience participation, no less.
There you go. There you go. Well, so really the number one thing I heard when I got here was primary care, primary care. We can't get primary care. So let me tell you what we've been doing with primary care, and I'm so excited about it. You should be seeing in the press in the next day or so, we sent a release yesterday that we have actually hired 3 brand new doctors who will start in September. So in 5 months, 3 doctors. So that's a 25% increase. So we have Dr. Steve Fader, who's coming. He's working in Maine right now, and he's a pediatrician. He's going to be the medical director of primary care, which consists of pediatrics, family practice, and primary internal medicine. We have hired a wonderful physician from, he's right now at Boston Medical Center. He was trained at Rush in Chicago, did his residency at the Mayo Clinic, and a fellowship in sports medicine at Boston University. And the third physician is another family practitioner. He's finishing his residency in Albany, and will be moving here with his wife, Amina, and their 2 children. All 3 of these physicians meet the number one qualification I had for physicians besides their pedigrees. You want to live and raise your families and be part of our community. And that's what all 3 of them have in common. And so I think that we've been putting Band-Aids on some of the coverage issues with locums and travelers. That's not good, consistent care for the community. And I'm appreciative of the work that they've done. However, it doesn't help you when you're trying to figure out who's my primary care doctor. In addition to the physicians, we've added 4 nurse practitioners in the last few months. Some of them are here tonight, and I think you probably read the article in the Gazette about them. They're a wonderfully talented group of advanced practitioners with lots of experience in different things, from diabetes to geriatrics to general care to women's health. So they have collective expertise and really specialized expertise. Together with the nurse, now remember this is important. I was doing this on the back of the envelope this morning. One physician generally can see and hold what we call a panel. So it's a total number of patients within their group per person, about 1,200 patients. I've just added 2 physicians, so we've gone from 8 primary care, family practice to 10. Nurse practitioners can see 300 patients. When I do the math, okay, and we have the capacity now to see 13,500 patients. What's our island population off-season? So that's 80% of the population we have the capacity to serve once they all get here and settle, okay? That's pretty astounding when you think of it. We have to work on a seamless way to get you appointments. I think we have definitely some process issues that we need to improve on. So we're getting these physicians in. They're looking for real estate, folks. Anybody real? Give me your number. And what's wonderful is, they'll be here in the fall. We're staffed up enough for the summer rush, but these are going to be physicians that are going to be here hopefully for the long term. And raise their families, and you'll have access to them. So we should have enough capacity. I would hire more physicians if I could, Okay, and I could. My phone's actually ringing off the hook. I had a call just before I came here today. I don't have the space. I have nowhere to put. Some of my NPs and docs are here, and they will tell you that we have about roughly 1.5 exam rooms per physician in primary care, and you need about 3 per doc to really practice efficiently. And so our docs are stretching out their hours of the day and adding hours at the end of the day and trying to come in on weekends to do their records. And it's not a good quality of life for them, but they're making it work. They're making it work. And that's why the space plan is so important. In the short term, we are working on a plan to take some of the vacated space in Windermere, move some of the administrative functions over there so we can utilize some clinical space on the main campus so that we have some space for these physicians. Not ideal. It's a Band-Aid for space, but until we have a longer term plan, we're not going to be able to do much more. So that's the good news. Our wait list, we had, I know the paper said we had 500 patients on a wait list. Let me explain that a little bit because it was a little bit, it wasn't clear. So those 500 patients represented 3 different categories of patients. Priority 1 are patients who have no primary care on the island. Those are our priority 1 patients. We had roughly 240 patients on that list. Every one of them, as of 5 o'clock yesterday, have received a call, an appointment, a new packet of information, a welcome package for a new physician, and we're getting follow-ups for appointments right through the fall. So if you need a primary care physician and you don't have one, we will make sure you have one, and we will have the capacity. The second group of patients are patients who already have a primary care physician. So they're already being taken care of, probably off island, but they want a physician on island. We want to give them preference too, but our number 1 preference is patients that don't have a primary care doctor. And then the third category is if you're already in our practice and you want to change your doctor for whatever reason, kind of puts you at the bottom of the list. Sorry to say that, but we have to prioritize, and that's how we've prioritized our patients. So that's what makes up the 500. But right now, anybody that was on our wait list for a new primary care doctor that didn't have one has been called. Did I get that right, Marcy? Thanks.
You had a question.
Hi, welcome.
Thank you.
My name is Janice Casey. I'm from Edgartown, and I have a quick comment first and then a question. My comment is that prior to moving to the Vineyard 17 years ago, I was involved with hospice for a long, long time. And unfortunately, it seems that we don't really have great hospice care available here or palliative care, good end-of-life care. And so, I think all of us would like to make sure there's good care available for us in that way. But the other thing is the availability of 24-hour sort of walk-in care, urgent care. Here, everybody ends up, if you need a doctor, need to be seen at night or on the weekend, you have to go to the emergency room, which is very expensive, and it's hours and hours of time there. So is there anything in the vision for making 24-hour care or evening and weekend care available, medical care available?
Let me, do you want me to address the hospice issue? No, just a comment.
Well, whatever you
We
would
do
like.
have hospice services here on the island, and
Yeah.
we have some contracts actually with the hospice agencies. And I might ask Carol Bardwell, our chief nurse, to maybe give you the background on that, just so everybody's clear what we do have. Thanks, Carol.
So we have 2 hospice services on the island. Thank you. I'm shorter than everybody else. So one is a Medicare reimbursed hospice, and they do provide services that way. We also have the volunteer hospice of Martha's Vineyard. If patients need to have palliative care or end-of-life care, they usually come into the hospital, and there are contracts with the hospice services to provide that.
Yeah, I've had a number of family and friends who have used the two hospices here. I'm just saying that, you know, because again, so many people come from off island, your physical therapist, your volunteers, social workers, you know, really the whole array of hospice services is generally not available. That's my experience. So I know people are trying to do the best they can, but it, you know.
And again, I think that turns into volume and scope, but we can definitely look into it a little bit more.
Thank you both. In terms of 24-hour urgent care, you know, unfortunately, it would be astronomically costly to staff urgent care 24/7. So that's really what our emergency room is for. We do have, given the added capacity that we now have in primary care, you should be able to see your own primary care physician for an urgent matter and avoid going to the ED. The whole team. That's right. Thank you, Marcy. That's why we've added the nurse practitioners, because if it is something that you need and your doc's schedule is full, your nurse practitioner can see you. So that's been an added plus for us. So we have added that capacity to get you in faster with your own primary care team. During the summer, when we have a surge of volume, we do have a fast track in the emergency room. So we have, you know, depending on your acuity, we have a nurse who will fast track you through the ED. And generally, the turnaround time is 1 to 2 hours for a fast track. So you're not stuck in the, you know, the queue of triage where patients who are much more acute and sicker would be, and you can get in and out faster. I wish we had the resources and all the money in the world to have it 24/7. It's just not feasible for this island.
Well, let me jump into a medical question. 2 words: Lyme disease. So concerns about the upcoming summer. This question, there's a series of questions, by the way, and that came in online. This is an online question. Concerns about this upcoming summer and treatment for Lyme disease.
So no doubt, we have the highest incidence of tick bites, right, in probably the whole state. And so I do want to dispel, though, that we don't have the expertise in Lyme, because we do. Our emergency room physicians are very well versed in diagnosing a tick bite and Lyme disease. Lyme disease is a really complicated disease, though, particularly chronic Lyme. And I'll be getting out of my safe waters pretty quickly here, and I'll ask Peter to comment. But chronic Lyme disease requires a lot of specialty observation and care, and we don't have that here on the island. The range of symptoms and the variety of treatment and expertise varies from expert to expert. So it is really key that you find a provider that knows you, understands your symptoms, and you and he or she can work together to understand your symptoms. Is it really chronic Lyme? Is it not chronic Lyme? It is a really complex disease, and we can diagnose it. But chronic Lyme is difficult to treat long-term. And I don't know, Peter, if I've expended my knowledge on this at that point, and I'll turn to you.
No, Denise, I think you have. I think, you know, obviously we're well versed in treating the initial, you know, presentation of Lyme disease, but chronic Lyme disease, like many things, can get very complex. And you know, I like to view our hospital as sort of a high-touch, low-tech place. We can't afford all the high technology and sort of the super experts. But the good news is that we have access to those experts. So a number of our chronic Lyme patients are seen at a place called the Dean Center, which is Spalding Hospital, which is one of the partners rehabilitation hospitals, and Dr. Nebovich and Dr. Crandall are 2 physicians that are sort of nationwide leaders in the management of chronic Lyme disease. And chronic Lyme disease often is treated, you know, requiring long courses of intravenous antibiotics. And so the approach that we've taken is, you know, patients go off to get the diagnosis, and then the management plan is shared with us. And when you're getting antibiotics for a year-long course, for example, you need special intravenous access called a PICC line. And 5 years ago, if you needed a PICC line, you had to go off island. And, in talking this over, I said, this is kind of crazy. People have to go off island just to get the special access to get the antibiotics. So I went up to Mass General and got trained in putting in these PICC lines. And currently we're putting in 50 PICC lines a year. We did, 5 years ago, we put in none. So that's 50 people being saved a trip to get intravenous access. But more importantly, we are then prescribing their antibiotics. So I personally write prescriptions for a prolonged course of intravenous antibiotics for a number of physicians that refer patients in. So we do try to manage the patients here, but we don't necessarily have the expertise. And I think that's often our focus is we rely on outside expertise to manage or to help us manage patients with difficult conditions. And then we try to do what we can here to facilitate the management so that a patient doesn't have to go off for a PICC line, they don't have to go off for an infusion, they don't have to go off for chemotherapy. And I think that's kind of the approach to Lyme disease. So it's a terrible disease. It's one of the hidden dangers of paradise, as we like to say. And, we do tell our patients, we do put out brochures, we do help sponsor community efforts to, educate people about ticks. And, they don't carry just Lyme disease, but other diseases as well. So.
Thank you, Peter.
Has anyone written a question out on the card that they received that they would like me to ask? If you have, raise your hand and we can go by and collect them. You see any hands up? No? Okay. Oh. Yeah. We'll be right with you.
I'm a recipient of a PICC line. Thank you.
Hey, Fred.
Here we go. Let me get this in front of you for you so we can hear you.
Denise and I have met before. I work at Windermere. I've worked at Windermere for almost 10 years. When I first started, there were no travelers, one, and now I believe we have 62% of the workforce that are travelers. I think the hospital needs workers that are willing to speak out against policies that are incongruent with their life's serving mission. And they must recognize also, the hospital, Windermere, that employees are human beings with human needs. If those needs aren't acknowledged and respected, the hospital struggles with personal issues and the organization struggles. What's your plan in bringing locals back?
Good question, Fred. Real simple. No. Thank you. It starts with, and Freddie and I have had this conversation, as I have with a lot of my employees, it starts with our core values. And more simply put, practicing what we preach. We can't say that people are our greatest asset and then not treat them with respect, not hear their concerns, be open and honest about what we can and cannot do. Patient care has to come first, so sometimes we have to have policies that don't always seem fair, but they always have the patient first in mind when we write them. I think the best solution, Freddie, is always to have, and I hope you have seen this since I've gotten there, that we have open conversations about issues. We have respectful conversations about them, and we really try to solve them together. So I think word of mouth is the best advertising, and when employees know that Martha's Vineyard Hospital is a great place to work, it's best sold by fellow employees, travelers or not. And I think we've only just begun, really. I think that there have been people there, have been there a long, long time, and they live the values every day. And I think that I'm not really tolerant of employees that don't or won't. But everybody gets a fair shot. And the dialogue has just begun.
Before I have you ask your question, for the two folks behind, you want to have seats over here? Just hate to have folks stand, and we don't want to make this a stress test on you. So if you're fine standing, so be it. Please, sir.
Hi, Doug Ruskin from West Tisbury. Your predecessor, by all accounts, was doing a pretty good job. And there were hundreds, if not thousands, of people quite upset over what happened about a year ago. Everything you're saying tonight is the right thing. I mean, I'm very comforted by what I've heard. I'm concerned from a governance perspective. Will you be here a year from now? I mean, you took this job knowing what had happened. So what assures you that you'll be treated differently?
Thank you. I have a wonderful relationship with my board, and I had a very open conversation with them when I decided to accept the position about, my role versus theirs. And, what I have discovered is our vision and values are really the same. A board has a little different role than its CEO. And sometimes I think we confuse governance and operations. And I think it's important to understand the board's role and important to understand my role. And that goes for our relationship, and Tim Sweet, who, hired me, Tim and I, we kind of saw eye to eye on that. And I believe Sandy Ray and I do too. And I feel the full support of my board. The board is looking to me and to us to create a strategic plan. They're not dictating to me what we should and shouldn't do. They're advising me, and that's their role. That's what good governance is all about. And I think we have now a very diverse board, a skill matrix that varies, and it's something we do every year now at our annual meeting. We look at, before we bring on new board members, we do a skill mix assessment. What are our talents and what are we missing? Do we have too many lawyers, too many bankers? But what's the skill that we need? What's the expertise? Do we have somebody well-versed in behavioral health and community services? Do we have somebody well-versed in reimbursement, third-party reimbursement, Medicaid, navigating Massachusetts Medicaid and some of the insurance issues we have there? So that's what we look to. At the end of the day, it's a tough job to be a board member. It doesn't pay very well, I can tell you. I love the fact that Chris Scott is a board member, and when we talked about Chris's candidacy, what I loved about his background in urban planning and open space planning, remember what I said earlier about a master space plan? I thought that Chris would be a wonderful asset to our board and lend a lot of credibility and thinking and expertise in that area. So, it's about looking forward. What do we need going forward? What's the vision we have together? And my job is to communicate with you and translate that to the board for what that vision should be. Did I answer the question for you? The Joe, the predecessor thing, I'm not going to talk about that. I never met Joe. I think I just have to do my job, right? That's, as long as I do my job, I'm going to be fine. I have no qualms about that whatsoever.
All right.
Hi, my name's Tina Davies. I'm
Hey,
from
Tina.
Edgartown. Hi.
You know what, Tina, let me just adjust that microphone a little bit for
Thank you. Oh.
Look at that, the magic.
How's that?
Didn't even touch it.
Can you hear me now?
Hard to
Thank
find good help,
But he's magic, so
Yeah.
that's important.
He is.
I want to thank you for being here and holding this. You made me smile because I can remember picking dandelion greens with my nanny.
Nanny, oh, that's what we called ours.
And it's not exactly a question, but I was happy to hear you talking about compassion, because I would say 99% of the staff has that compassion, but there's always people that don't. So I'm happy to hear you emphasize that. Like I said, it's not really a question. It's just a.
No, I
I'm happy to hear
appreciate
it.
that.
Thank you.
Thank you. Thank you.
Thank you very much.
It's at the heart of what we do. It's what we are. Do you know the Greek word for meaning of compassion is a sympathetic understanding of man's pathos. A sympathetic understanding of man's pathos. That means understanding that there is suffering there, and we have to try to understand that. And as caregivers, we have to be compassionate.
First, I'd like to welcome you.
Thank you.
exactly 1 year ago today, the movement started, the concerned Citizens Committee got together, began to get together and became assembled to try to deal with the issues that we saw as being a completely unresponsive approach to the community. And I'm delighted today to be able to say that it looks like some good things have happened. It doesn't feel like a year, it feels a lot longer, but I'm very pleased by some of the things that we have seen.
Thank you.
The one concern I have is about the board itself. And this was one of the issues that was talked about time and time again, and we got no response from the board. And so my question to you is this. Many of those board members have been there for a very long time. I was glad to see during the year that the issue of term limits came up, but I didn't see that actually anything was going to happen. And our group was asked to put forward recommendations. And to the best of my knowledge, those recommendations have not been followed, were not followed. And we had some really, really good people that we put forward. So my question to you is, are we going to refresh this board? It's been there a long time, and you know, many people believe in term limits, and I think this is really necessary. My name is Alan Briggish, and I'm from West Tisbury.
Thank you, Alan. Yeah, so, you know, we're in a period of transformation and transition, and I've received many great suggestions from the citizens group, and they actually helped me with this meeting tonight and helped prep me. You know, Len, so wonderful to be setting up the AV. And really being a conduit for your concerns and issues, and really a sounding board for me to shape my perspective, get a deeper understanding of the issues. So I will say that on the term limits, the term of a board member is 3 years. So a board member is elected for 3 years. The new bylaws say that, and the officers didn't have term limits. That's the point I think, Alan, you were talking about. As of May last year, the bylaws were amended and restated such that officers serve for 1 year, 1 year. So every year at the annual meeting, whoever's an officer has to be reelected, okay, renominated and reelected. And that's when Tim has chosen to step down. We have a long tenure on the board, so to take every officer off the board, we decided that we would rotate them off based on their term and the new term limits. Okay, so you will see Sandy Ray, our new board chair, is 1 year as an officer, and his term expires at the end of next year. So the term limits are in effect. We do have some openings on the board, and Peter and I and others have been talking to some people. One of them, who you guys recommended, okay, and I'm not going to say his name yet because I want to make sure he accepts. And I had a wonderful conversation with him. And as soon as he comes back from his son's wedding in Copenhagen, I think you all know who I'm talking about. We'll have a further conversation about it. So, So we are listening. We are listening. And again, like diversity, the board and the organization is enriched by different talents and perspectives. And that's what we intend to do.
Sir? Thank you. My name is Bill Croak. I live in Edgartown, and you mentioned substance abuse, and I just wanted to make sure it got an airing. Ever since we moved here about 10 years ago, substance abuse has been the #1 public health problem on the island, and it's kind of, I think of it as the invisible killer because it's not really broken leg in your face, but I do see a lot of suffering, and that's why I'm here. The hospital did a needs assessment. It was published early last year, and as I recall, the #1 and #2 highest responses had to do with substance abuse. I know the hospital traffics a large number of people through their emergency department every year. with substance-related problems. Now, I know that there are treatment limitations and licensing issues and so on and so forth, but I did want to ask the question, how do you see going forward the hospital's role in addressing this issue on the island?
Thank you. So indeed, substance abuse is a really complex problem, and it's prevalent here as well as nationwide. Here on the island, when I first got here, the first thing I tried to do was assess what we had, because I kept hearing, we don't do anything, we don't have services, and yet I had all these people meeting in my office saying, well, we're the substance abuse counselors, and we're this and we're that, and I'm thinking, well, we have services, I just am not sure how they're integrated or if they are. So we have spent some time meeting with community members, meeting with community services, and meeting with my own team internally to understand roles, responsibilities, intersects, and handoffs, right? And to be better organized about that, because you know as well as I do, it's a disease that takes an army really to work with, and there's a continuum of care that is important to the cure. I can be a safety net in my emergency room for crisis, which we often are. So overdoses, injuries from, intoxication, et cetera. But that's just the pit stop, right? That's not the way to get long-term care and help. So we've been talking with community services. They just opened their crisis center, and where they'll be doing more Suboxone. We do have some providers that have their Suboxone license. The problem with that is all of the other services that go with it require social services, long-term counseling, family counseling. We know that this is a process and it takes a village, right? So I think that we have a bunch of services on the island. We have to figure out how to weave them together tighter and create better access. We also have access to off-island services through our affiliation with Gosnell, so we can get people to a detox center with our detox coaches and our substance abuse coaches and our own substance abuse team. So I think that, we have a lot to do in this arena. We do. I don't have an easy answer for it, but it is working together to collaborate on the resources we have and making sure all the intersections take place and there are the appropriate handoffs. It also starts with the patient. Go back to what I said earlier, when there's a will, there's a way. So we have to find patients with the will and help them find the way.
You've been waiting patiently.
I know.
Please go ahead. Yep, you're next, please.
My name is Tessa Permar, and I'm from West Tisbury. And I want to say thank you so much for hosting this. And I really appreciate you bringing up Lyme disease. And I hope I can ask a quick, more specific question. The lab testing protocol for Lyme disease right now is a 2-tiered testing process that was formerly recommended by the CDC. So that means that patients are offered or given the ELISA test, and they must receive a positive or equivocal result on that ELISA test before they can receive the Western blot. That's the second test that the hospital provides. But if people don't test positive on the ELISA, they are denied the Western blot. And the ELISA is only 40% accurate, which means 60% of people could be getting inaccurate testing, false negatives, which happened to me for 20 years. I had classic Lyme symptoms at age 6, at age 13, at age 18. I was finally given a Western blot off island. Right away, I had a positive, strong test. And I just want to ask if there's a way that we can, A, get the Western blot, easier access to that, and B, just perhaps some training, because I had classic symptoms and I know other people have, and I'd love for us not to slip through the cracks in the future.
Thank you for sharing. Would you like a job? You know a lot about this. Thank you for your candor. And That is way above my pay grade, I'll have to tell you. That's one for Peter or Dan in terms of the lab testing.
Yeah, so, our providers follow the recommendation of the Infectious Disease Society of America, and we can debate the technicalities and false positives and false negatives.
Peter, they're saying they can't hear you. Back there. Can you get closer to the mic?
Sure. Every test has some level of false positive, false negative, and they're using combination to sort of decrease those ratios, and how accurate they are and what they miss are open to debate. And no test is 100%. And, I'm sorry that you weren't picked up on the Western blot, but certainly providers can order a Western blot separately from an ELISA. The ELISA is sort of a generalized screening test, and it picks out the higher risk patients for sort of higher level testing. But no test is 100%, so sadly people do get missed. And technology is evolving. We're hoping to shift towards PCR-based detection, which should be more accurate, so that people will still get missed, but I think fewer, so that the specter of having to suffer from chronic Lyme disease, which no one really should have to, hopefully will be less. And I think that's where we're headed. But again, no test is perfect, and we try to do the best with what we have, and that's where we're at.
All right, so we'll go here and then to you, all right? But you've been kind of, can you have, is there a seat that we can have you?
I'll just hang on.
You sure? Okay, all right.
My name is Ann Floyd. I'm from Edgartown. Following on sort of what Alan was talking about in terms of the board members and improving the board, I would request, if you aren't already doing it, that the board members be made acutely aware of Windermere. I've always felt that the existing board in the past treated Windermere like an ugly stepsister, and that's just not okay. So I'm wondering what you're going to be doing to maybe introduce them to not only the hospital, but Windermere in particular.
Thank you, Ann. So many of our board members have actually asked to start to do rounding at the hospitals, and we will absolutely make sure they're rounding in Windermere. I can assure you they are acutely aware of our issue in Windermere because of the financial issue that we have. So it's discussed at almost every board meeting. But what that is an opportunity then to discuss with them the challenges, the issues, and the alternatives, and to really engage them in a strategic discussion about the future. When we put together a strategic planning committee to look at all these things, they will be board members on that as well as community members, Ian. So, they've been hearing me talk a lot about it. Chris can affirm that, and I think I saw Edward or somebody else, a couple of other people here, but it is top of mind for me, and believe me, it is top of mind for the board. Thanks.
Please.
Sorry to make you wait.
That's okay. I'm Diane Holt from Chilmark. I met you before.
Oh, yes,
Coming out of the
Diane.
emergency room with a
Yeah.
little broken toe at one time.
That's right.
I first would like to make a comment, try to be politically correct, that for 25 years I have treated acute and chronic Lyme disease, put in PICC lines and midline catheters in people who could not leave their homes. I put the midlines in the homestead. So I'm aware of some of the issues related to that, but I also want to beg you for a job because I think that I'm qualified and I don't have to come in at top dollar. I am an RN scientist. Please take a look at my vitae again. That's the first comment. The second comment is to the lady from Windermere. I am also aware of the sort of discrepancy and the respect issue between the hospital and Windermere. We're all here for each other, and that support and respect needs to be addressed, and maybe a forum of the people get together and work on how to accept each other because you're all valued in the community, and also for your education and the way you take care of people. But that's not my question. My question.
Wait a second
my
now.
question
Wait a
is.
second.
My question.
Where are my guidelines?
Now that I lectured
Okay,
you,
okay.
my question is this. It's a positive thing. It is because of the lengthy hallways and bowling alleys we have. Would it be possible for you to take a look at maybe having the golf carts for transportation to make it quick to get people around and where they need to go, and also a way to help people who need that? So I think that would be a really viable thing to consider. Thank you. That's my question. Bye.
Thank you. Golf carts at the hospital. Anybody know any owners of the golf courses? You know, getting around the campus, all kidding aside, is it doesn't seem like a big deal. You know, I came from Boston where, you know, Tufts Medical Center spanned 10 city blocks, right? So, but when you think about the perspective of it, it is really tough if you're walking with a cane and you're down in orthopedics, for example, and you need to go to the lab in the x-ray department. It's on the other side of the hospital, right? So, you know, long-term plan would be to have those adjacencies in a new setup so they're closer to where the patients need to be. In the meantime, though, we can look at, and we are looking at the front lobby space and better staffing the information desk and making sure there's wheelchairs available and potentially transporters, because I have noticed how difficult it is for patients to get around. It's difficult for me to get around, tooling back and forth all the time. But I do intercept patients all the time and try to lend them a hand. At the very least, we could have more wheelchairs and transport services. Thank you.
Yes.
Hi, Denise.
Hi.
I'm Merritt Bazaler.
Hi, Merritt.
We've spoken on the phone.
Oh, yeah.
I had an interesting experience. I went in for an elective screening and a colonoscopy, and I was asked the screening questions. How much do I drink a week? Do I feel safe in my home? Do I think about self-harm? And I said, you know, so what about the big question? And they said, well, what do you mean? I said, am I in recovery? Do I have a problem with opioid addiction? And she said, oh, well, we don't really ask that question. And I said, well, what if I did have an issue? What would be the protocols for medication?
Yep.
And she said, oh, well, I guess we would not give you anything. You could do it without medication.
Good.
And I said, and if I did say yes to self-harm, then what would be your response? And she said, well, we would get you help. And I said, well, where would you get me help? And she said, well, we have a staff member that would come down to talk to you and make sure that you got the help that you needed. I said, well, what would that look like? And she said, well, I'm not sure. And so I guess my question is there a plan going forward for better screenings for addiction or recovery? Professional development around what that could be, what the choices are, and what it looks like if somebody actually said, yes, I am thinking about self-harm.
Yeah.
So those are my concerns, and I'm wondering what the plan is going forward.
We obviously need to do some more education. From your experience, certainly that tells us that. I think that, you know, depending on who the staff are, you know, they may not know all of our protocols, so we need to make sure they're clearer, because we do have very strict standards about what we should ask, what we need to follow up, and who we need to call when we think a patient might be in harm, certainly. And the substance abuse work, absolutely we should screen for that, and I do believe it is on the questionnaire for Peter. I don't know, maybe you can help me with what alternatives to anesthesia we've been discussing. And I mean, we just had a patient go through a hip replacement and had no opioids for pain management. So there was a definite interaction about managing my pain without opioids, without certain chemicals. So we want to be very involved in that conversation with our patients. So it sounds like we need more work to do.
Thank you. I'll sit down.
Thank you,
as
Ann.
respond.
Yeah, so we could spend 3 hours here, as we have in the past at community forums, but substance use, which we all know is a scourge on this island, but also across the country. And obviously screening is a great way to identify people at risk, and it's something where a lot of work needs to be done. And my wife, Karen Casper, actually is very involved in concept of substance use, and particularly thinking more, obviously, management of people who've been afflicted, but also if we can prevent people from falling victim to this in the first place, then I think our work down the road is easier, and screening clearly, like in the emergency department. And one of the things that we're looking at is we're using a fairly new to us medical record program called EPIC, and it has some screening, cage questionnaires, screening kind of questionnaires that in a few questions you can determine if someone's at risk. The big point which you raised is then, great, you're at risk, now what? And I think that's where we need to do all the work, is figuring out, we asked a question, but what are we going to tell you that we can do for you? And so for self-harm, we do have social work, so we'll bring our social worker down and try to evaluate sort of the acuity of the situation. As far as undergoing a medical procedure, just because you have a substance use issue, or, thank God you're in recovery, that doesn't mean that you don't get pain medication. Anesthesia has evolved. We do colonoscopies all the time on patients in recovery or patients who are actively using, and then we switch out to sedation. Does not involve benzodiazepines or narcotics, so we do propofol sedation. So some of it is training. So if our staff is saying, well, you can either do this or grin and bear it, that's not the correct answer. And so it's an ongoing dialogue, it's ongoing education, and there's a lot of work to be done, but it is on the radar. Yeah.
I actually asked, what is the medication that's used? And she said fentanyl, but it's not like the fentanyl you find on the street. And I'm thinking, it's exactly like the fentanyl you find on the street.
And
so
I apologize to you. I do a lot of colonoscopies, and I'm sad I didn't hear about that when you were there. I don't think I did your colonoscopy. And we're not going to get into we're not going to get into the HIPAA thing here, but I think
no personal.
It's education, right? So fentanyl clearly is a very potent narcotic. It is fatal in small doses, which is why it's really affecting our community and communities everywhere, is because you're dosing this stuff in micrograms, and you just can't do that out and about. But I think fentanyl, it's education. I mean, you worked with a staff member that was not educated. So if you're in recovery, if you're actively using, we wouldn't use fentanyl. We have alternatives. And the medication is called propofol for all of those of you who want a procedure where you don't hear or feel anything, but don't want narcotics, ask for propofol.
Well, I would have assumed that the person screening me would have had that as an option. It
Agreed.
isn't actually something that I am struggling with, but I started asking questions because I felt that there were holes in the questions being asked. And I also wondered, what does it actually look like if you are in active addiction, or if you are considering self-harm, what are the services? Because I have been down this road with a family member several times, and I'm wondering exactly, I want to hear from you what that looks like, because I know from experience what it looks like. So I want to hear what you feel is already in place that maybe wasn't my experience, or how much of it is contracted out, and is that working? And so that was sort of the second piece of this bigger picture of my experience and my questions.
Thank you for bringing it up. And obviously, the only way we can get better is by taking and appreciating your feedback. And so when you give us this feedback, I know I've got to talk to Carol and say we've got to work with our nurses and explain to them what happens when the question is answered. We have travelers. It's hard keeping everybody on the same page, but it clearly shows that we have to do more. So thank you for bringing it up.
And well, what is the protocol? So if I had an issue and I needed help with either self-harm or
Okay, so
addiction,
self-harm, I briefly
that.
mentioned we have social work that can tie you into the right resource for self-harm. We have a robust substance use team. We have several, 3 counselors on staff that we would call in, and they would tie you into the resources that you would need to, depending on where you're at. So, different situations might require a different level of intervention, but that would be the role of the substance use disorder team.
Thank you for your question. I think we had someone here, and then I will get to you. Please come forward.
Hi.
Hi. Turn that down a little bit for you.
Thanks. My name is Patsy McCornack, and I'm from Vineyard Haven. And my question is this. I'm a great fan of nurse practitioners, but I sense that a lot of people insist on seeing their doctor as opposed to a nurse practitioner. Would you discuss for the public the role of the nurse practitioner, what their education is, and also the role of a hospitalist?
Sure.
Thank you.
So our nurse practitioners have advanced practice degrees, so they have to go through special training, special clinical training. They have a scope of practice that is higher than a nurse, that allows for independent activity, diagnosis, treatment, and in some settings, the nurse practitioner is used as the primary care provider, like at the health center, for example. So very well trained. Here in our practice, we have a combination of nurse practitioners who do independent practice and they collaborate with their physician advisor. And it's a new model for us, so we're still working on that. Having a nurse practitioner isn't instead of your doctor, it's in addition to your doctor. And I think that's important for the community to understand, because I've often heard people say, oh, I have to see the nurse practitioner. Well, I have to tell you, when I have to see my doctor in Boston, I actually prefer to see my nurse practitioner because she spends more time with me. She doesn't give me hell like he does. And she's more available. So that relationship develops over time. And that nurse practitioner works with your physician when you need higher levels of care. They work in a very integrated way, and that's what our patient-centered medical home model is all about. So I hope that answers the role of nurse practitioners. Hospitalists are, it's a fairly new field in medicine. I'd say, I don't know, 5 to 10 years potentially. So the days of our physicians coming to the hospital, rounding on you after they've done a full day of patients in the office, doesn't work that way anymore, right? So what a hospitalist does is they're assigned to you as when you're in your acute phase of care. So their job is to work in the hospital, round on you in the hospital, communicate with your primary care physician. They are trained in acute medicine and hospitalist medicine. It allows the primary care physicians to practice in their offices, to see more patients. Many communities, you can't hire a primary care physician if you don't have hospitalists at your hospitals because they can't work all day long and then be on call at night for their patients. So this is an adjunct to the care model in medicine that is, not my grandmother's kind of medicine or not even, my mother's kind of medicine. You'd say, where's my doctor? And so it takes some getting used to, but these are highly trained physicians in acute medicine who can follow you through the course of your care. Usually hospitalists will work 10 days on, 10 days off. So they're following that patient through the whole length of stay. So you don't get a sporadic provider. So they get to know you, they know how you're progressing, they're following you, they hand off to their night person, but they work, usually 10, 12-hour shifts, so they cross over on shifts. And it just creates a better continuum of care from the inpatient to the outpatient setting. Okay.
Would you clarify the relationship between this hospital and MGH and partners? For example, it often feels like, and this is my own word for it, there's almost a quota of patients that need to be shipped from here to Boston, when in fact it would be easier, more accessible to go across 7 miles of water to other healthcare providers that have services that we don't have here. So one would believe that you are required to ship people to MGH. Am I correct?
No, no, we're not required. It is better patient care when, because we're connected by Epic, where we have a relationship with providers. We share the medical record, which we may not share with an offsite provider who's not a partner's physician. So first and foremost, we respect patient choice, and patients do choose to go off island for their services. We promote the continuum of care between us and our partners because we think it's better care. It's better quality, it's better coordination, there's better real-time information. You can go downtown, they pull up your medical record, you don't ask the same questions 100 times over. So you're part of that continuum connected by our electronic medical record in a world of specialists that you sure can't beat. So there isn't a quota. We, I think because of our hospitalist medicine program and some of the specialties we've been able to bring here, we are keeping more patients on the island. And it's only when we're really sure we can't provide the care or the patient might not be safe do we ship them off. And sometimes in emergencies like traumas, for example, if MedFlight comes, they go to the next hospital up on the MedFlight roster. They don't always go to Mass General or to Partners. So we don't discriminate when there's emergency care. Dan, were you going to say something? Yep. Thanks.
I think it's important to realize that even before, because we've been asking about the board and that kind of thing, I'm the chairman of the Medical Staff Quality Committee, and we review every transfer out of the hospital. And we've had a number of programs that have come out of the review of those transfers. We have now a telemedicine program through the ED so that patients who are being evaluated for possible transfer, we work with Mass General and they say, this is somebody we should be able to care for here. And we have a care plan that's put together, much like Peter was outlining for Lyme disease or other outpatient care. We do that on an inpatient basis as well. But the board has always, and to be quite honest, I've wanted to do away with the review of every single transfer. We review things that fall out for all sorts of care issues. But this is one that the board has always asked. They want to hear about what goes off island. And not just to Mass General, because we have patients who request, hey, my cardiologist is in Falmouth. I'd like to go there. And they go there. And I can tell you from a maternal standpoint that very often Mass General has an 18-bed NICU. They really can't always care for the newborns that we have to transfer. And so we work with Tufts and a number of different places. And, we don't, we talk to Mass General first and they help us through the process should we be transferring, but oftentimes they're helping us place in other places. So, and the same goes for patients who have issues during surgery and have to be transferred emergently. Mass General works with us to make sure that people are getting to the care most quickly, and the board wants to hear about that. And so they use that actively to look at the programs, and that's why cardiology right now is a big issue, because we could, with even just a non-interventional cardiologist, have a little bit more care on the island. They're working on helping us do that. So nobody's ever told us about quotas, and the board has actually driven the other direction that, they're all like the rest of us. We'd like to be able to stay on the island when we can. And again, back to, if we can provide the same care that you would get at another institution. And that's always the tough part. And if we don't, because we do have patients who choose not to be transferred, and then it's a matter of, well, we can't provide this, but if you understand that, we're going to do our best to provide the care here. So it's always complex, but it's one of the big things that the board wants to hear about.
Thank you,
So I'm
Dan.
just going to do a quick time check because it's exactly 6:30. If anyone needs to leave, please. We understand it was promoted from 5 to 6:30, but I would ask if we could just stay for a couple extra minutes and go through some other questions just that we received from the email. Does that work for everybody? Or can we stay a couple extra minutes? All right, we're going to call this the lightning round. Quick answers. Parking. Not even a question. I just say it.
It's a problem. It's a problem. So we actually have somebody looking at our current parking right now to see how they can carve out some more parking spaces. So we have some dead space around the facility. So we're hoping to carve out about 8 to 10 more parking spaces. We also ask, and I'll use this as a public announcement, please don't use our parking lot for park and ride. Please don't. I see it every day, and I've seen people that just park there, somebody picks them up, and the car's there from 8 in the morning till the next day sometimes, and sometimes days on end. And, we can turn a patient parking space over 8 times in a day, one space. So imagine when someone parks their car there. So I'm not saying it's anybody in this room, but and we have recently leased some space. The PA Club, this is our busy season. We've had a staff up, so we have some spaces where we incentivize our employees to park off-site to create more patient parking. So I know it's a challenge. Carpool if you can.
Did you have a question? Please,
Thank
come
you.
on down front.
I'm Dr. Mary Jane Williams. I'm a nurse, 53 years of practicing
Oh, wonderful.
critical care and a professor. And I'm also a very strong nursing advocate. And so you're reformulating the board and you're adding people to the board, and nurses make up the core of the hospital practicing staff. And I have served on many boards, and I know nurses are sometimes a little bit intimidated by serving on boards, but it's a wonderful experience. So my suggestion is, would you consider adding a qualified nurse to the board from your staff and your hospital?
Are
Because
you throwing your name into the hat here
no,
tonight in a public setting?
no, I'm not. I'm suggesting that you have somebody who is very familiar with your hospital, with the members of your hospital, with the practices, because I don't believe many people understand the role of the nurse. And, I see nursing from a completely different global perspective. And so I would hope that the nurse you select to do that would bring that to the table.
Thank you. It's a good. I don't know if you know this, but I was thrilled when the governing committee voted in Debbie Burke is a nurse as our new vice chair of the board. So Debbie Burke is the chief nurse at Mass General. She's a doctor of nursing practice. She brings just a wealth of knowledge and sensitivity about quality and performance in nursing practice. And I can assure you, she lives in Edgartown. She has a home in Edgartown as well. And you would probably love to meet Debbie when she's here one of these Fridays. But well taken. It's a really good idea.
Thank you.
Yeah, thank you.
Thank you for that. How's the hospital doing financially?
We're having our ups and downs.
I'm sorry, was that an awkward
Thanks,
question?
Peter.
I don't mean to ask awkward questions.
Yeah. So we're a little behind budget. We're sort of neck and neck where we were last year. We're entering our busy season, so hopefully we'll be making up some ground on volume. So our biggest issue has been volume. And, that's always a blessing and a curse, right? So, but the business side of me says more volume, because that's more revenue. And, we've seen a big shift. Some of the causes are, we've seen a big shift from inpatient to outpatient. So for similar services, we just don't get paid as much. We've also made investments this year in primary care, the nurse practitioners, which weren't in the budget. And, our losses at Windermere continue. So right now, year to date, we're about $3 million off of budget. That was through April. We haven't closed May yet, and I see it here, but we haven't closed May just yet. And I think our volumes are starting to tick up. So we should be okay by year end. My goal is to make sure we break even by year end, and I think we'll be on our way at that point.
I really like this question. Someone wants to know why the information desk is not properly staffed.
Every place I've worked, that information desk is a problem. So it should be staffed. It absolutely should be staffed. And, I did a poll in my last job to figure out how people were staffing their information desk, because I wanted to employ some people, and I found out that nobody employs people to staff their information desk. It's all based on volunteers, and that's not always the perfect solution because it's hit or miss and who's there, and sometimes they can't go get a wheelchair because they're just not able to get a wheelchair and transport somebody. So I'm really thinking about a transport service and really staffing an information desk. So the hospital has many main entrances, right? You all come in from very different ways, and probably more from some of the side doors than the main entrance itself. So that's the other challenge we have, is now we have these multiple areas where we really need to station some people to give guidance and directions. But it's a good point, Peter, and we need to do a better job at that. I hate to see that desk empty. I stand there a lot just to say hello to people and give them directions. It's the best part of my day.
So once again, that came from our online survey. This won't be a question. This is just, we need you to take note of this. When will the ceiling above the loading dock door be fixed? Just saying. Just saying. So seeing no further questions, let me ask the last question then. And again, it comes in from our online survey. How will the conversation started here tonight at this forum be maintained?
Well, this is just the beginning. So we hope to do more forums. We are looking at, let me introduce my new Director of Communications, Katrina Delgadillo. Katrina has done an awesome job. Stand up, Katrina. Katrina has come up with so many great ideas about engaging you. This whole venue tonight was planned by her. She's really working our social media much more actively than in the past. I would say our communication process and systems are now starting to ramp up. We've talked with the Gazette about doing a health page. So we want to have more open conversations and transparency so you guys know what's happening at the hospital. It must happen. And I'm inviting you in. I keep looking at people that know my door is open, have come to see me, and I encourage that because the best dialogue is face-to-face, right? And we're not that big of an island. So I asked, people have come, they've been respectful, they've had good ideas, and so let's keep the dialogue going. And we'll work together through some of our other community groups, other forums, and when I see you in the line at Kronig's.
They're perfect. Any last words to the group tonight?
I am just so grateful for the turnout tonight and for this opportunity to reach out and talk to all of you and to hear your concerns. And it just underscores how thrilled I am I made this decision to come out of my sabbatical and my garden and away from my retired husband to do this job. It really is a calling, and I take it very seriously. I think I have the best job on the island. Thank you.
Well, thank you all for being here tonight, and I just think you should all give yourselves a round of applause for the terrific questions that you asked. So a round of applause. I want to thank Denise and her team at Martha's Vineyard Hospital, and I want to thank again the AV team here at the Performing Arts Center, MVTV, Len Morris and his team at Galen Films, and to all the community members who offered their support. Thank you, and we'll see you down the road.